All right, we're going to finish up and talk about a few more things about chronic kidney disease. We ended up talking about this last little component on the slide about glomerular filtration rate. In your book, there's a good example of all of the different ranges of what this is that someone goes through, but the two that I want you to pay biggest attention to is chronic kidney disease is defined by a glomerular filtration rate of less than 60 that has lasted for 3 months. And then when the filtration rate really tanks out at below 15, then they're considered to have end-stage kidney disease. And as you can imagine, with that low amount of filtration, they are really, carrying around tons of electrolytes that are not being removed from the system, lots of metabolites, protein metabolites that are staying in the system that are causing problems. And we'll just talk a little bit about some of those as we get into it, but just know that it really is a condition of that GFR. So when you're looking at lab work, that's one of the key things that you really want to pay close attention to, because it tells you not just BUN and creatinine, but how long has this been a problem, and is it how low functioning is it at this point. There's a good place in your book that really breaks down this filtration rate by the stages, and I would just encourage you to kind of look at that in terms of seeing how someone progresses through that. But again, the biggest thing that we're going to really focus on is end-stage disease. There are a lot of changes that you're going to see in terms of the kidney function itself. How much filtration is going on, how much urine is actually being put out, and eventually patients have so little excretion going on that they become completely anuric, meaning that they're not putting out any urine at all. And so, you see somebody, you always want to pay attention to that, because somebody may have been having some function and had a Foley catheter in, and for 2 days there's been no urine output, and that's not uncommon. And that is a real key issue when you're at that point. There really isn't a reason for somebody to have a Foley catheter in, because if it's that minimal, it doesn't really matter. But you will see ongoing kidney declines because in that way. Metabolic changes, protein metabolism occurs in the body, and you see breakdown of proteins into urea and creatinine. So the higher those levels are, they're not being excreted out of the body, and that's a good sign that your kidneys are not functioning properly. We've seen that on BUN test and creatinine test and lab work. But knowing that those are getting worse and worse is again metabolic changes that lead to, when you have high urea and high creatinine, they get into a very acid-base imbalance that causes metabolic acidosis. Sodium, potassium, calcium, and phosphorus, you want to be really paying attention to those levels in the bloodstream, so getting those labs drawn frequently, or maybe around dialysis time is important to see where people are pre and post. So people do get a lot of blood drawn, and that has an impact on things as well. With sodium, you can have increases in sodium because they're not excreting the sodium. You may have normal levels. They may then retain fluid, and they kind of get overloaded with fluid, and so then you get diluted out again, so you might be back to having low sodium. So, and if they do have sodium retention, that can lead to a lot of other issues. They can go into congestive heart failure and have other problems with edema, pulmonary edema, lots of problems that the sodium can cause. Potassium is generally going to be increased, and that is just because potassium is not being excreted. It's staying in the bloodstream and not being filtered out. And so what are you most concerned with that? Cardiac arrhythmias are huge and can be life-threatening and deadly if the potassium gets to around 7 or higher. So clearly, any increase of potassium in these patients above the norm, you want to have them on a cardiac monitor and really be paying close attention to that. As I said, they can be in metabolic acidosis. So you have to think back, what is that we've learned about already? Diabetics go into metabolic acidosis when they're in DKA. So, how we talked about patients having Kussmaul's respirations as a symptom of that. It would be something to really pay attention to. What is their pH balance? So those kind of labs are important. And then calcium and phosphorus I'm going to discuss on the next page. And then magnesium, you want to pay attention to what meds that they're ordered on or what meds you might get an order for, because they may have normal to a little bit higher magnesium levels in their blood because of low excretion, but it really can get worse and have some neurological changes related to it if they're on meds that contain magnesium. Things like a lot of antacids have magnesium in them. So paying attention to what those levels are is important as well. This is a good depiction that gives you a good idea of kind of how kidney failure really messes up phosphorus and calcium. So try to get this really memorized in your brain. As your kidneys fail, your GFR goes down very low, and so you kind of really decrease your phosphorus excretion, and because it's not being excreted out through the urine, then in the bloodstream, in the serum, the phosphorus is much higher. On the other side of the map here, the kidneys are responsible for activating vitamin D. So when your kidneys are not working, vitamin D is not being activated, and then the calcium that you're taking in through your diet is not being absorbed. So you get issues with, they're not absorbing the calcium, so your calcium goes much lower. In response to that, your parathyroid gland, as we learned about endocrine, cranks up, trying to, in that cycle, well, now we've got to get more calcium to come out of the bones to kind of offset that. So then the patient's bones become demineralized. So you expect somebody in chronic kidney failure is going to have serious issues when they look at x-rays and the condition of their bones. They're going to be osteoporotic, high risk for fractures and those kinds of things. And then as those bones release calcium, you may get an increase in calcium as well. So with calcium, you kind of want to see what's going on, to see what stage are they in and how is it affecting them, as to whether the calcium may be high or low. But your phosphorus is going to always be high because it's not being excreted. All right. I'll talk about this more in detail, but under cardiac, I wanted to make sure that we really break that down into a few cardiac things that come. As you can imagine, when you have all this backup of metabolites that aren't being excreted, as well as electrolytes, long-term problems occur with all of your other body systems. So chronic kidney disease leads to really failures, particularly in the cardiac system. These patients may have had hypertension that caused the kidney failure, or they may have hypertension that's caused from being in kidney failure. They can have hyperlipidemia. They can often go into cardiac heart failure because of fluid retention, can have pericarditis. And I'm going to talk on this next slide a little bit about some clinical manifestations that we see. Review your chart in the book, which is 68-4 in your textbook. It breaks these down into great detail, and I'll let you review those on your own. I did want to mention, related to respiratory, you may see pulmonary edema come from fluid overload. You may see patients having Kussmaul's respirations because of metabolic acidosis. You may see patients go into flash pulmonary edema. So those are some pretty significant respiratory things you would want to respond to. Cardiovascular, in addition to those things I mentioned, they may have significant arrhythmias because of the potassium that you want to monitor for. Neurologic, they may have, often they're very irritable or listless, withdrawn. They can be, sometimes get confused because of the high levels of electrolytes. So they're often a very difficult patient to manage neurologically and psychologically because they have an end-stage disease that is not reversible. So emotionally, they often don't cope well and often don't always want to be compliant with treatment, which makes managing their care a lot more difficult. Hematologically, they do get anemic, and this is really, if you remember, the kidneys produce erythropoietin. And erythropoietin is the thing that makes your bone marrow produce red blood cells. So if you're not producing red blood cells, you're going to, as those red blood cells go through the lifespan and they die, they're not being replaced. So less and less red blood cells, less and less hemoglobin. And then they're getting their blood drawn really frequently. They're also can have bleeding from their GI tract. And then when they're on hemodialysis, they're on blood thinners, which add that on, along with the dialyzer itself pulls off sometimes some extra red blood cells. So often these patients are having to get transfusions. And sometimes those are done while they're getting dialyzed, which is nice because it's done at one time and the nursing staff on the floor are not having to handle as much. GI issues, they're going to have stomatitis. They'll have a very uremic type of halitosis or breath odor. They can have nausea, vomiting, a lot of other issues that go along with this disease. Skeletal, we just talked about. Urinary, we've talked about. Skin, they will have buildup of the uremia into the dermis of the skin that causes severe itching, redness, skin breakdown, and it will actually come through the skin, causing a condition that's called uremic frost. And I want to show you just a picture of that. This is literally where the protein is built up so much that it's leaking out into the surface of the skin. Of course, you want to look at your assessments for psychosocial labs. I think we've talked about all the different kind of values that you'd want to get more detail on. Imaging, the other thing is going to be, we talked about, how the kidneys can be affected from CT dye. So just know that you're going to do imaging on these patients to kind of see the condition of the bones. Or if they had, potential fractures, but you're also going to be very careful with using contrast dye with these type of patients. This next list just kind of goes over the priority care issues. You want to keep them on a low protein diet because they already have too much protein in their system, that's not being excreted. Low sodium diet, often be on fluid restrictions. family members really helping with their care is important.